Inside the numbers on Arizona's COVID-19 crisis. I'm Steve Irvin, filling in for Katie Rammel, who normally does this segment on Facebook Live. And joining me, as always, is our Arizona data guru, Garrett Archer, going over some of the numbers. And the numbers are the key, I guess, in trying to figure out exactly when we can reopen. The question that everybody wants to answer: when are we going to get back down to a point where we can say, we're in the clear and we can start reopening schools, bars, gyms, other businesses as well. Garrett, I think we should probably start with the Arizona data dashboard, I guess, with the health department. What is that showing us today?
Okay, so today, just to remind everybody that today is a Monday, and Mondays are always a low reporting day. So just with that being said, we have about 180,000 cases total, 179,497. That is over the course of the entire pandemic. Today we added just over 1,000 cases, 1,030 off of 7,990 PCR tests. That is the lowest number of cases that we have added since June 1st. This is the first time since June 1st that we've had a day over day increase of less than 1%. And that is even taking into consideration that Mondays are a low reporting day. Deaths, 14 deaths reported, but as we've seen before on other Mondays, very low numbers on Mondays typically. In fact, last Monday we had a -1 death total showing here. So really we have to wait till tomorrow to see what deaths are really going to look like for the week. But right now that's what we have. Our percent positive has remained at 14.4%. That is the cumulative percent positive of diagnostic tests. And then the 5.3% for the serology tests.
So overall, we're seeing a downward trend, though. I mean, overall, we've got a lot of encouraging news to report in the numbers, especially when you start to factor in the epi curve and the 7-day moving average and some of the things that really show us where the trends are. When we go in and backfill some of those cases that are reported today but may have been from a week or two ago, we're still on a downward trend, correct?
Yes, and I will take you to those epi curves and the ways to sort of see where the trends are. So we're going to go to a site. We don't go this very often, but this is confirmed cases by day. And this is what our actual case epi curve looks like. As you can see, we peaked on June 29th at 5,450 confirmed cases on that day. But since then, we've had a fairly aggressive downward trend of cases that have been reported. And the other place to go see this is at the laboratory testing portion of the dashboard. And we'll go down here and we'll look at this. This is the percent positive of the diagnostic tests. And I'm going to keep this at the week so it's easier to see. And you can see that we had our top week for percent positives was at 21% on June 28th. And then here, 19% on July 5th. And then you see right now we have 16, 13, and although we haven't fully completed the week of July 26th, we're at 11%. So our percent positives have fallen for about 3 weeks straight at this point.
I've got a question from Kim Altenhoff Tunney, and it says, does the lag from the weekend apply to hospitalizations, ICU, and deaths, or does it just lag in testing?
It does apply to the lag in deaths. It does apply to deaths. That's why we have such a low reported number today and why we wait for Tuesdays to really make a determination on what deaths look like, because tomorrow we're going to see pretty much a lot of the deaths that may have occurred this weekend will pop into the system tomorrow. As far as hospitalizations and ICUs, they do not have a lag in this particular portion of the dashboard. I will show you this right now. I'm going to stick right now to the COVID-19 specific metrics. These are beds that are reported. This is a bed count of COVID-19 possible or suspected patients that is done every day by the hospitals. And so this we can sort of use this as a good metric of what's going on at the hospitals. And you can see for the inpatient, we've had a clear downward trend since about the middle of July. And we'll go to ICU. We can see it was sort of going down, but at a slower rate, because obviously ICUs lag hospitals. Someone checks into a hospital and then they may need an ICU a little later. But you can see right here, after 7/28, we start to experience a fall off of ICU beds. And then just to keep going, the discharges are going down too. We haven't seen a discharge number this low since June 29th. And then emergency room visits, This is also at a very low point. 1138, it continues to fall down. So all in all, the hospital assets for COVID-19 look very good.
We often get this question in these discussions about how many. John Nichols is writing, how many people have recovered? Why don't you report that fact? Recovery numbers are well. Tell us a little bit about recovery numbers. What we know, what we don't know.
So to remind everybody, the reason we don't report recoveries directly is because the AZDHS has not settled on a definition of what a recovery is. So because of that, you have some counties that are giving recovery numbers, but most of these are not technically recoveries. They're more, the case is no longer active. So sometimes the definition is 28 days. The infectious period of this disease is about 14 days, anywhere from 14 to 28 days. But for reasons of the fact that it's an epidemiological issue, they don't report recoveries per se, because they can't determine with truth that anybody who is that they just can't say that you've recovered. There's other things that could happen to you over the course of time that makes it so that you haven't recovered. That being said, we do have some ways to sort of check case activity. When we look at this curve, we say, okay, the infectious rate of this disease is about 14 days, and it could sort of be anywhere from 14 to 28 days is sort of the active period of this disease for most people. And what we have for that, we do report that number, and it's about 18,800 cases that are aged over 14 days, and then 61,000 that are aged over 27 days. So the sort of rate, what we have here is we could have anywhere from 18,800 active cases to 61,500 active cases.
I wanted to talk about a specific number that I know we touched on Friday, which is the under 20 numbers. And when I look at the data dashboard and I go to the demographics part of it, it shows, if I can just click on that, it shows that when you look at the number of under 20 overall positive cases, it's up there. It's up there actually higher than the number of people over the age of 65, and I believe over the number of 55 to 64 as well. Does that indicate anything to us in terms of either the testing of young people or the rate of spread in people under the age of 20? Because I think there's still this general idea that kids are not as affected by this because the death numbers are very low, but the case numbers are still quite high.
Correct. So we do have, like you said, the under 20 is about 12% of cases, and it is a little higher than the over 65. Now, with that being said, we have seen over the past week or so that under 20 has begin to increase at a slightly faster rate than the other age demographics. We did see this early on in the pandemic, that the age demographics for the under 20 was increasing at a faster rate. And then that sort of stopped once we went into lockdown and opened up. And then we saw the 20 to 44-year-olds really start to increase. And now what we're seeing is we're actually seeing sort of a back to that reversal where we're starting to see the under 20 getting this disease at a slightly higher rate. So I'm going to show you something really quick. I'll try to interpret this. Hold on a second. Let's do this. Sorry, I click on one thing one time and sometimes it doesn't work. So let's go here. I'm going to share my screen. And this graph is confirmed cases by age at a per capita of 100,000. And I'm going to try to go through these here. This checkered box right here, this line right here, this is the 20 to 44. This line right here is the 45 to 54. This line right here is the 55 to 64. Hard to see this one. I have to fix this graph, but right here is the over 65. And then right here at the bottom, this is the under 20. So you can see, even though they have grown at a faster rate than the other age demographics, they are also still and remain by pretty decent margins the lowest impacted age demographic of this pandemic so far.
So when we look at the under 20 numbers, my understanding is it might be helpful if AZDHS sort of broke that down into different age categories, because what we're understanding about kids going to school, for instance, is that kids under the age of 10, for instance, generally the data shows that there's very low rates of transmission and very low rates of hospitalization. But as you get beyond the age of 10, suddenly those numbers start to go up, or the possibilities start to go up for transmission. Do other states do this differently? Do you know? Where they kind of break it down for school-age kids, for instance?
I do know that there are, obviously there's various reportings all across the country, and yes, there are some states, I believe California is one of them, that does report on a younger age demographic. Our Department of Health Services has decided to keep it at under 20. We do have one county, Yavapai County, which does report numbers for 12 and under, and then 13 to 17. So they have, you have a better idea there. I did see something this today from actually the University of Arizona that did have some numbers that were a little different. I'm going to try to track that down if I can, because they did have some of the demographics that we're looking for. I'm not actually sure where they got those numbers yet, so I have to find out if they got those from the AZDHS or if they're doing some sort of estimate using statistics.
So, Garrett, as it stands now, it's August 3rd, exactly 2 weeks before August 17th, which is the date that Governor Ducey has said schools can, if they choose, open to in-person learning for students. And there are a number of districts that do plan to do exactly that, opening on August 17th. I know it's still 2 weeks away, but we also have access to modeling and various projections based on where our numbers are right now. Can we tell at this point whether we're going to be at the point on August 17th where we're actually going to meet the gating criteria that has been set by the CDC and the White House for reopening schools?
Well, that's an interesting thing, and the reason it is because 2 weeks is sort of the issue with this entire data reporting process from the beginning. We find that it takes about 2 weeks to really get the lines to settle, to know what's actually going on. So we may see some fluctuation in the numbers on the daily reported, but we really don't know what truly happens until about 2 weeks. So right now, at this very moment, things look very good as far as all of those downward trajectories of percent positives. However, as we've seen back in May, things can turn on a dime here. So, from 2 weeks from now, if things stay sort of in the same vein as they are now, we could be at a point where we're seeing percent positives under 10%, which would be great. However, we don't, it's just difficult to make that determination. We do have, let me see if I can show some modeling here as to where they think things are going to be. This is the MIT model from Yu Yang Gu. It thinks that we'll go to August 17th here. It believes, as you can see, it believes that we are going to still be on a downward trajectory at that point. It believes that it will have about newly infected 13,000, anywhere from 21,000 to 6,000. And that is test independent. That's just going to be, people that this is community spread, if you will. You can see the currently infected by that time. It believes that we're going to have anywhere from 360,000 to 100,000 people in Arizona that are currently carrying the virus at that time. And then for the totals for how many people, we see about 1.8 million Arizonans have had the virus at that time.
And so at this point, we really don't know whether we'll be there. It's still kind of a aspirational date, so to speak. Yeah, because things can change pretty quickly with this. So far, we've had a good 2 weeks of a sustained downward trajectory in the reporting. We are looking, one of the good things is we're starting to see that tomorrow we'll hopefully find out definitively if Sonora Quest is done with its backlog. We haven't detected any backlog for the past 2 days, so it appears that they're done with the backlog, but we'll find out sort of definitively tomorrow if they are done with the backlog. Yeah, that sort of answers the question that Donna Grolau was asking here in our comments section. Has Sonora Quest caught up on the backlog? They had promised to do it by this weekend, we should say, correct? Yes, and we would have seen it if they finished it yesterday. We would have seen it today. So we're kind of looking for tomorrow's report to see what those PCR numbers look like and how far back cases are being added and tests are being added. Because if tomorrow, which is typically a much larger report than today, if those numbers are not backlogged to a large degree, then that realistically means that Sonora Quest is probably done with their backlog. I want to talk a little bit about hospitalizations and some of the hospital numbers that we're seeing, and I know that there are certain numbers that you take more seriously than others because they're more indicative of what's happening right now. For instance, emergency room visits for COVID-19 is an indicator of where we are, and maybe helps us kind of cut through the noise when it comes to that 14-day backlog. Those are more current numbers. How do those numbers look at this point?
So those numbers, the emergency room visits right now, and you are right, they fluctuate to a much larger degree than the bed counts for inpatient and ICU. And we have seen sort of from its peak, which was 2008 people showing up in emergency rooms on July 7th. We have had a sustained downward trend. However, interesting, if you look at the week-by-week numbers from July 21st to July 28th, it has definitely slowed. I'll bring it up really quick to just show how it's sort of, you can see sort of the change in not the direction, but the change in the slope. You can see for these 2 weeks, you can see a very quick degrading, if you will, of the line. That's just descent of the line right here. But then when you get to July 21st, you see that the line has essentially slowed down a little bit. So that could mean, like you said, emergency room visits. This is our best leading indicator that, you know, there's what's going on out there is it is still going down. The R naught is still going down, but it's now going down at a slower rate.
So when we look at some of those emergency numbers, obviously that's an encouraging sign as well. You and I talked, I think, before we came on here on the broadcast, and from what I understand, the White House gating criteria says we have to be essentially on a 14-day decline to get to what they call phase 1. And as you were pointing out, you could argue that we're in phase 1 based on certain criteria, but not others, which sounds a little bit like the manipulation of numbers. But explain that a little bit. Like if someone
Sure.
claims that we're at 14-day decline, it basically depends on how you interpret the numbers.
So I'll show you exactly what that means. So, you know, when you're talking about a 14-day decline of percent positives or case numbers, there's sort of two ways to look at it. You can look at it with these aggregated weekly numbers, which you can see has a sustained downward trend from July 5th for about 14 to 20 days now, where we have gone down to the percent positive. Now, the other way to look at it is on the day numbers. So, you know, is every day truly going down? A little harder to see this number. So I'm going to bring up a different chart here for a second so you can see. But, you know, because when you look at it during the day, you won't always get a sustained downward trajectory of testing of percent positives. So I'm going to bring up one more chart here. Let's see if I have it ready to go immediately. Let's see. Yes, I should have it. Just 2 more seconds. This is the gating criteria for the rolling average of cases. And you can see we do have a gating day. If we're looking at it by date, we do have it at 4 days right now of sustained downward trend. But you can see this is what we're talking about as far as the gating criteria is concerned. We could have had a 14-day, but we did have these little upticks right here that sort of canceled out that sort of downward trend for the day, and now we're at day 4. So tomorrow, the next day, if the trend goes up, we're going to cancel out that day again, and we're going to have to start over.
And so they do a 14-day decline, not based on like an epi curve of 14 days, but actually, you know, consistently showing lower numbers day after day, basically.
And that's a good point. See that, and that's a very good point. When we have the ability to look at the epi curve numbers that we're not going to see from places like COVID tracking or from COVID exit strategy or any other places that scrapes data from the AZDHS, because they're scraping the reported numbers. So, and as you said, we could see, and we've seen differences here. You can see like there'll be an uptick tomorrow in the numbers from today, and people say, well, look, they've gotten worse, but that doesn't necessarily mean that we're in an upward trajectory of cases by day. When we look at the epi curve, we could still be going down. But again, the epi curve takes about 2 weeks to stabilize. So we won't really know what's going on for at least 7 to 10 days, 7 to 14 days on an epi curve.
We get a lot of comments on here about deaths that are supposedly attributed to COVID-19 that really weren't COVID-19 numbers. I know that Dr. Christ came out, I think it was last week, and tried to clarify exactly how they determine a COVID-19 death itself. Can you talk a little bit about that, or maybe explain exactly where we're getting that? Because I think that's a common conception that people have, is that, you know, that somebody died on a car wreck or in the heat, and that death was attributed to COVID. She attempted to clarify that last week.
Yeah, so I actually asked her this in an interview last week because I wanted to get to the heart of this. I know a lot of people think that there could be situations in which deaths are being sort of upcoded, is the terminology they use. So what she told us is that this sort of begins. Let me start a little bit earlier. She said that this sort of kind of begins with the claim that hospitals are making more money with COVID-19 patients. And while it is true that based on the Federal CARES Act that hospitals are making more money on treatment of COVID-19, that's sort of where it stops. They don't get extra money if a death is marked that a treatment wasn't marked. So you have situations in which, what people are saying is people are marking deaths as COVID-19 to upcode and get a little bit more money. So there's a couple things wrong with that. A, the attendant physician is the one that certifies the death, not the hospital, and they don't have a financial incentive to upcode on behalf of the hospital. And two, you've got these OIS, you've got investigative units that just try to make sure that the coding for these deaths is proper. And no doctor is going to, not many doctors are going to basically put their license at risk to mark a COVID-19 death. It's just, it could be, now there could be situations, obviously there was a situation in Florida where there was a time when a motorcyclist that had tested positive for COVID-19 was marked as a COVID death. And that would be considered an outlier. They did look at this and they said, yeah, that was coded that way. It was a mistake, and they removed that. So these can happen, but Dr. Kara Chris did tell us that if this happens, it will be an outlier and it will be removed. So we don't have that. We don't have it bearing out in the data. Doctors we've talked to have said that this doesn't occur, and if it does, it's extremely rare.
And when it does occur, as you pointed out, they do remove it. That happens pretty frequently. We just don't see it necessarily in the reported numbers, because the number that we have, a number of positive deaths, for instance, would be the number of deaths reported versus the number of deaths where they went back, reviewed it, and said, no, that's not actually a COVID death. Correct? Yeah,
we do have times that deaths are pulled back. And that does happen on the EpiCurve. We're not given an explanation to why these deaths are pulled back. Sometimes they are re-added at a different date, and sometimes they don't show up again. So there are times that this does occur as far as deaths being pulled back. It can happen. These are all investigative processes. This isn't something where somebody has a death certificate and they look at it and say, okay, I'm just going to code this for time immemorial and it's going to stay this way. It's going to be investigated to make sure that everything's right.
So when one of the questions I've had for some time is when we see that downward trend, and we know that there's a 14-day lag, and then the state goes in and backfills some of those dates where the deaths actually occurred. Does that mean that we look at the last 14 days of that curve with maybe a little less credibility? Those numbers aren't as solid as we would like them to be, just because of the lag in reporting?
Yes, and I'll go over that as well. I'm rendering the chart right now. And when you look at the EpiCurves, you always want to take sort of the most recent, anywhere from 7 to 14 days, with a high degree of skepticism. And again, this is because this is an investigative process. It's not necessarily, you just don't want to interpret, say, oh, look at how quickly deaths are going down, when you don't have that information. And this was a problem back in July when we were at the peak. Now we have a very sustained number of decrease in the curves. So you can easily and obviously see that there has been a sustained decline. This is the case EpiCurve. You can see on this, I have a 7-day rolling average that ends at about today, 4 days. So it's saying that I'm confident, this is the curve telling me that I'm confident that the AZDHS is not adding a whole lot of cases to the curve after this point. You can see the light blue, they have added some cases here and there past the yellow line, but really the majority of the cases that were added today came right here where the line stops. This is the same thing with the case numbers. You can see that a lot of the cases were added right here, and there's very few here. Please forgive this. I believe that this is a coding error on my part. I'm going to check that. I don't believe that that is the case, that is a true number. But you can see that there are always numbers that are added in. Sometimes even it's hard to see, but there are numbers that are taken off too. So I'll go back to deaths really quick. That was the cases in the tests. And this is the deaths. And you can see right now, especially since we had a very low reporting day, you had very few deaths added to the curve. You have a couple. You do have one here from June. You have a couple in late June, a couple in mid-July, and I think one here from this last week. So this number, this curve is really, I keep this at a 10-day curve because it takes so long for deaths to be added to the chart. But you can see still, even with that 10-day curve, we're still right now at a very sustained downward trend on deaths. I don't know if it's going to hold. We're going to have to wait till tomorrow and the rest of the week to see what happens. But right now it looks encouraging.
Let's talk a little bit about testing, because I think one of the concerns, there was one comment on here that says testing has been cut in half. I don't know that the availability of testing has been cut in half, but the governor has himself acknowledged that there's been a significant drop in demand for testing. What are your worries about that? Because certainly knowing where we stand on COVID-19 in Arizona depends a heck of a lot on having widespread testing and people actually going out and getting those tests and getting those test results back quickly. When we have fewer people getting test results, does that naturally make the data less accurate?
Well, it doesn't necessarily make the data less accurate, but it makes it less telling on what's happening in the community. I brought up the test epi curve here because I want to just sort of tell a story of what's going on, what you're talking about. Here, back in early May, April and early May, a lot of these tests, you can see there was not a lot of tests going on at that time. And in fact, a lot of those tests were happening at long-term care facilities, and they were targeted populations, long-term care facilities, healthcare workers, places where people were most at risk, and you had to have symptoms to get a test at that point. And you can see at some point, it dropped a little bit. And then here is when the community testing truly took over at this point, and it just shot up. So this is when people were getting tested in the community, and this is where we started hitting the backlog. We've started to drop off that now. So if we're in a situation where testing demand's not there, I mean, we can't control testing demand. Testing demand is testing demand. But if we get into a situation where the state is back to testing targeted populations, healthcare workers, long-term care facilities, at-risk populations, then it sort of it will for at least a couple weeks give us this sort of rosy picture that isn't real because things are getting worse in the community. And it takes about 2 weeks to figure out what's going on. So that is a concern right now, is that if things start to go back up, we won't know for about 2 weeks. And then, at that point, we're chasing it at that point.
Margaret D'Angelo wants to know about ventilator usage here a little bit. And I just pulled that up on the dashboard. Those numbers appear to be going down as well, which is obviously an encouraging sign because it would show that fewer people are getting seriously ill and in need of a ventilator. Yes.
And we also have, just so everyone knows, like as far as the hospital census numbers, because we didn't go over those as well, but just to look at them really quick. We're seeing pretty much a sustained number of hospitalizations from the peak. We can see that hospitals are doing their best to manage care right now and also get in those elective surgeries that they had to suspend at the top of the peak here when they were worried that they were going to get too many COVID-19 patients. So we do have, this is intensive care. You can see that at the peak, at about 91% was the peak. We're at 83% right now. It's been a very slow and gradual decline. It's because they're taking in other patients. Same thing with inpatient. Inpatient numbers have stayed pretty stable. And again, this graph is COVID agnostic. They're trying to get they're getting through those elective surgeries and the other things that they need to get through right now.
We haven't touched this session on R0 numbers, but you should probably start by explaining what R0 is, but it's an encouraging number for the state of Arizona. In fact, when we can compare ourselves to most other states, we are doing pretty well with that number.
Yes. So to remind everyone, the R0 number is basically the number of people that estimated a person can transmit the virus. So right now, our estimate is at 0.9. The easy way to look at that is if 100 people had COVID-19, they are able to transmit that to 90 people. So obviously over time, in that sort of scenario, the virus starts to burn out because simply there's less people for it to get. So this number does change frequently. I'm going to darken my screen here so you can see where we are on the curve with the states. You can see right now we do have, we are the second lowest R naught. Vermont has 0.88, and it also has a lower error bar than ours. I always like to remind everyone to make sure you always look at the error bars when you're looking at the R. Very important. Right now, and this is actually quite encouraging for Arizona. As you can see, our R naught at the low end is 0.69, and the high end is 1.05. The best situation we can be in is at the point where the R naught is even the error bars are under 1. So we're not there yet. So basically they're saying that even though we think that the virus is slowing, there is still a possibility of the virus increasing because your R naught is still over 1 at this point.
So a good number there and a good number to report. The governor has certainly said that based on what we're doing in the state, it appears to be having an effect. Do the graphs match what the governor says? Because the governor put an executive order into place, closing down bars, closing down gymnasiums, water parks, and that sort of thing. And it certainly appears, at least I'm an amateur at this, but it certainly appears that when we went to some increased restrictions on COVID-19, that's when we really started. About 2 weeks later is when we started to see the numbers decline. Is that accurate?
Yeah, that is accurate. That's totally accurate. And we also saw, we saw numbers declining. It took a while for us to get to the testing backlog, which was very frustrating. We also did see Arizonans, their mobility index started to decrease as well. So obviously right after the stay-at-home order lifted, the mobility index increased sharply from close to 0 to about 50% of normal traveling. And it stayed there for sort of June and July. And then once we put the mask order in place, you saw that number start to decrease gradually. So it not only did the restrictions likely do something to mitigate the virus, but Arizonans just by themselves decided to sort of slow down their traveling.
So when we look at all of these different numbers and we look at a number of the key metrics, most of them appear to be going down. Are there areas of concern where we're still seeing numbers go up?
I would say as of right now, it's what I have to tell you, I'm going to want to look at the zip code numbers for that. I don't have that ready for now. I'm going to have to look at it and get back to you as soon as I can, because one of the concerns could be that we're having targeted hotspots in certain areas like the West Valley. The West Valley had still been increasing in case numbers by pretty substantial amounts the last couple of weeks. So, concern would be that while everything sort of statewide is looking very good, we could still be having some very isolated hotspots that are very concerning.
When we look at the criteria and look at sort of reopening criteria, how close are we to getting there? You mentioned that if you interpret the numbers a certain way, we're at 14 days, so perhaps we could start seeing things reopen. And it appears that the health department's sort of willing to allow some places to reopen if they fill out this form and certify that they've actually met some of these requirements that the state is requiring. But when people go, when are we on the other side of this? And when do we meet those criteria? Are we still a ways away? Or are we getting close?
I would say that if we use sort of the example or the definition that most experts are looking for, they're looking for a 5% positivity of tests. We are not at 5% right now. We're good. We're much better. We're about where we were at 11% so far. But they really want to see 5%. If things keep going, and now that the virus, or excuse me, that Sonora Quest is got the capacity to handle the testing, we could start seeing getting to this 5%, especially if sort of a requirement for opening is for, like, I don't know, just this is just pure speculation on my part, but if like sort of places say, okay, in order to come back to work, you do have to take a COVID test or something like that, because that would increase the number of community tests that are happening, which would bring our numbers to 5%. It's hard to tell what's going on when there's very little testing demand. It's hard to get to that 5%. Now, I'm not saying that we just start arbitrarily testing everybody. You know, you have to have some sort of plan in place, but that 5%, a sustained 5%, is where people want to be, or states want to be.
Kristy Gumpp Butz asked this question: are hotspots based on where we rest or where we reside? I think what she's getting at there is this idea that when we get cases and deaths reported, sometimes those cases and deaths that are reported in zip codes where there's a hospital, where the case would initially be discovered or the death would occur, and isn't necessarily reflective on the communities that we're seeing where we actually see those increases. Is that something that trends in the numbers? Have we been able to sort of isolate that down? I know I've been told the same thing by a doctor friend of mine.
Yes, and that is true. She's on the mark there. There are times, at least initially, that the case could be recorded by the zip code or where the test is done, but ultimately over time, it's going to the ultimate location of the test is going to be at the zip code of residence. It might take a couple weeks to get there, and we have seen that. I have a acquaintance of mine on Twitter that actually doing a very good job of dissecting zip code data, and they have a graph, a map. If I can pull it up sometime during this thing, I'll pull it up, and it'll show where case numbers have decreased over a period of time. And the only way on a zip code map for case numbers to decrease is for the departments to assign them to different zip codes. So that's likely what's happening, where you have zip codes saying, okay, this was a hospital, and now we're moving it to the residents because we actually have that data truly filled out at that point.
When we see the hotspots, though, correct me if I'm wrong, they tend to be in lower income areas?
They are. As you can see right here, we'll go to South Phoenix here. And these areas, let me get this up here. You can see that some of the largest, some of the highest zip codes here in this South Phoenix area, which has it's got a low income, this entire area. And on top of that, the Yuma zip code, this also has a fairly low per capita income, and you can see 4186 at that point. So this is the highest impacted zip code in the state right now. It has been for some time, and it's a low income zip code. So yes, there is truth to the cases running more rampant in low income communities.
Great. Garrett, I think that's going to wrap up our time for this edition of Behind the Numbers, and I appreciate your time. I appreciate the patience with all of you who are enduring me for a day. I know Katie Ramel is much deeper in the weeds on some of these numbers, but I do appreciate all of you standing by, and thanks for all of your great questions as well. Certainly, it looks like we've got a lot of good news to report, and that a number of the key metrics are starting to go down, and we're seeing that sustained over a period of time. And so hopefully that gets us a little bit closer to where we all want to be by being able to reopen some of our favorite spots and reopening schools and those kinds of things as well. Garrett, thanks so much for joining us. Appreciate it. And thank all of you for joining us as well.